Each of us on the panel have a very different perspective. I think you're unique in that what you've worked with GE is actually much bigger than any of us in that you've worked with whole cities. Mm-hmm. So the notion of looking at data and health around a city, what does that mean? I mean, how can we actually put that in perspective and learn from it?
So just to give context, so GE is about 340,000 employees. And we cover about 500,000 to 600,000 lives. So we actually care about folks' health in a way that is both to the bottom line and also because of productivity. Now, that's one thing within our walls, but one of the things that we've learned too is that healthcare is local. It's not just within the walls of a company. You've got to look at it within the communities you're living in. And the stakeholders have to come together, self-assemble, if you'd like, to figure out what they can do programmatically to help citizens, the community, et cetera. When Jeff Immelt about 6 years ago, this was before the ACA was formed, he was looking at his healthcare bills for GE, which totaled somewhere around $3.2 billion, just to give you a sense, and increasing at almost double-digit rates. He could not wait for the government to just say, this is what's going to happen, or someone else tell them how to actually manage this. So what he did in Cincinnati, because it's one of our places where we have a very big footprint up there because of our aviation business, was essentially called together leaders of other big employers, Procter & Gamble, Kroger's, Federated Stores, et cetera, and essentially said, we're large self-insured employers. We write the checks. And it's interesting, when you write the checks, people show up. And invited in the provider systems, the community, a whole bunch of different stakeholders, and essentially self-assembled. And that was the start of our Healthy Cities program, if you'd like. And we've been able to roll this out with self-assembled, self-directed types of goals, not only in Cincinnati, but in Erie, Pennsylvania, and Louisville, and also in Houston. And we've just recently launched what we call our Healthy Cities Leadership Academy, where we launched 400 competition amongst cities, of which 9 won, and are now participating in a year-long program associated to what should we be doing as it relates to health. What are things, to your point, can we measure to actually improve upon? Which, by the way, there's no universal health metric to your original conversation. So this is some of the programmatic efforts we're doing. You're seeing that cities really have become the center of what can move programs forward across the board.
So what's the answer? I mean, what have you come, I mean, what are the number 1, 2, and 3 things that we can measure?
Well, measure is we're still working on what exactly can you measure, but we are physician-centered medical care. Essentially, we're seeing more and more having someone that actually helps coordinate your care is actually very, very important. Number 2, having the kind of platform, and we're talking about big data, that people can actually participate from an interoperability perspective. The consumer isn't participating as much yet, but the provider systems are just starting to get something out of it so that they're actually making some decisions associated to that. And the third thing that we've learned is that depending on the local context, Houston, obesity, versus, I don't mean that for the whole city, but I mean that was what they picked as the actual thing to work on.
They like things big in Texas.
It's big in Texas. But and in Cincinnati, on the other hand, what they worked on was pediatric asthma, for example. And they were able to, both of them are measuring how to do things associated to their populations with the provider systems coming in and making a difference associated to that. And they're measuring it via cost and also via health.
That's great. James, 1953, Jeremiah Morris published a paper in Lancet, the British Medical Journal, where he had 2 classes of workers in the British Transit Authority, 26,000 people. Half were the bus drivers that sat 90% of the day, and half the ticket takers that walked up and down those double-decker buses. They weighed the same, they lived in the same environment, and smoked the same, yet dramatically lower heart disease and cancer in the ticket takers. We've become a society of bus drivers, right? We sit all day. You know, the more important you are in your company, the closer your parking space is to your desk. You've developed technology that, in a sense, can quantify and hopefully change behavior in this regard. Yet, me as a doctor, even if though it's one of the biggest risk factors for heart disease and cancer, it's not even recorded on my electronic medical record. How are we going to get what you do to change medicine and change behavior even more?
Yeah, so there's a few things. One, I walk to work every day, so
All right, good.
that's a positive step. But I mean, you're right. I think there's an explosion in patient-generated healthcare driven by Fitbit and other companies that have really done a great job in making consumers very aware of the benefits of tracking their lifestyles and behaviors over time, whether it's their activity, their nutrition, their sleep patterns, et cetera. And that unlocks a lot of potential because obviously a lot of what goes on in people's health happens outside of the doctor's visit. And right now, the doctor really has no visibility into what the patient or the consumer is doing outside of the series of questions and the exam that's performed at the visit. So for us, the promise of all this data is really the ability to screen people more effectively for different types of risks and disease conditions. It's the ability to give them more personalized treatments and guidance as well, and the ability to monitor people throughout their treatments, whether it's some type of digital therapy like CBT for sleep disorders, or whether how effectively you're responding to a particular drug, whether it's prescribed or OTC. So that's where we see a lot of the promise. And it has been actually a challenge for us to work with the healthcare system. I think we're making a lot of strides. Where we have made a lot of progress initially is actually in the employer space, particularly in the United States, where employers are bearing most of the cost of the healthcare of the U.S. population. And there, I think a lot of employers are looking for any type of innovative solution to try to address their employees' health conditions. And the good thing is that we're starting to see a lot of data that shows that there's positive ROI from monitoring employees on a more continuous basis. We actually have a couple studies that show that at least people who've engaged in Fitbit-powered wellness programs, employers save about $1,300 a year on average in employer healthcare costs per employee. One particular example that came out recently for us was the Dayton Regional Transit Authority. Their annual spend on healthcare is about $15.5 million, and we're able to reduce that by about $2.3 million or so this past year. So there's signs of this, I think, and we are making strides in trying to integrate more deeply into the healthcare ecosystem. There's a lot of barriers there. I think there's just issues like doctor education, training on how to effectively use this data, and that goes down into the workflow as well. All of this has to be integrated into the HR EMR, because otherwise I think a lot of doctors just don't like to have side-by-side systems. But the barrier there is how do we get the data into these systems?
Right.
How do we get an intuitive user interface that makes all of this a seamless part of a doctor's workflow. But those are, I think, all surmountable challenges.
What did you think about, I mean, not to change the subject here, but it certainly goes along those lines, the court case last week of AARP, suing the EEOC, saying that corporate wellness programs have the potential to invade our privacy and potentially cause discrimination down the road?
Yeah, I mean, I don't want to count on the merit, recount on the merits of the lawsuit, but I do think that from our experience, employers are highly sensitive to the privacy of their employees' data. I mean, there's cases, in most cases, where employers have come to us and said, look, we explicitly don't want to see this data. If we do see it, we only want to see it in an aggregate form. And we actually only work with employers that sign up to our Employee Bill of Rights, which basically says that we're not going to share your data with third parties. We're only going to share your data with individual opt-in consent. So I think there's a lot of agreement and alignment between ourselves, the industry, employers in trying to protect employees. And I think everyone's goal, I think we can't forget this regardless of lawsuits, is that we want people to get healthier and we want the cost of that care to be affordable.
That's great. Kathy, you've seen some of the, obviously, you've got to peek under the skirt of the research programs, well, in a figurative sense, of the remarkable research programs ongoing in our country for the last 7.5 years. And there's a lot of excitement, and I think all of us, are really excited about what's happening. But what keeps you up at night? I mean, what worries you on the negative side? I mean, what are you scared of? I mean, you've seen the positive, We see those announced. We rarely get the negative announced for what's happening on that side. What worries you?
So we're in the process now of designing a research program where we hope to invite 1 million or more people to participate in this precision medicine cohort program, which is now called All of Us. And the thing that keeps me up at night is security, data security. So I think sometimes we sort of overreact about privacy, and sometimes privacy concerns stand in the way of actually doing what's in the best interests of a research participant or a patient. But having 1 million people's data and lots of it is going to be a big fat target, and so that's what keeps me up at night. You know, we're going to talk, I think, over the course of the next couple days a lot about big data, but I think we have some real challenges with small data. So today, I can't easily get my medical record, even though it is a legal right. I can't find out information about the quality of healthcare providers, even though it's collected, I can't get it. And then oftentimes when you participate in research, you, the participant, are not getting access to your own data. So I think we have some real lessons to be learned from small data that then we can take to a big data context.
And who's in charge? Whose job is it to fix those 3 problems you laid out?
I think it's all of our, it's a problem for all of us, right? So the government can't solve these problems by ourselves. Certainly having the NIH director and the FDA commissioner and the CMS administrator working really closely together is really remarkable and inspiring, but they're all going to be, gone in a couple of months. So I think it's all of our responsibility to do that, and we have to have the will to demand that we have access to the kind of information that's going to be useful in making healthcare really consumer-driven rather than, a random selection, really.
Certainly, it's a dream. I mean, we'd love it, but we've been talking about this for a long time.
Yep.
I certainly hope there be change.
Yep.
Dana, you look at things from a very different angle. I mean, obviously different than most of us in that, you look at the economics of it. What works, what doesn't, how you change behavior through economics, et cetera. How do we change the culture in our country from one of treatment to one of prevention?
Well, I think you've hit on the fundamental question, and I think a little historical context is useful here. So if you think back 50, 60 years, and this is why the title of your book is so apt, really when we talked about how do you improve health, and that's what you asked, it was really a disease-based model. If we can do something about mumps and rubella very early on, you had a dramatic effect on someone's life expectancy. But we've made progress against those diseases. And you go back, fast forward 20, 30 years, then it became about early heart attacks. And if you did something on cardiovascular disease, and you could intervene there, you could really move the needle. Now we're, in some sense, victims of our own success, because if we make progress in cardiovascular disease, then we have to worry about cancer. And if we make progress in cancer, we have Alzheimer's disease. The competing risks as we get older are enormous. But we're stuck with this culture that has been a disease-based model. And the question is, how do you change that? And the reality is that the nature of what we're looking for out of health has really changed, because you're talking about people at the end of their lives, or end of their life cycle rather than early on. When someone's young and they have mumps, we know we got to get them better. But if someone's at the end of their life and they're thinking, do I want to make it to my daughter's wedding, or am I very active and I want to make sure I need a knee replacement because, part of my existence is having incredible, perfect functional status versus someone who just wants to walk around. And so these challenges mean that health is very heterogeneous now in a way that it never was before. And in addition, and you foreshadowed this in your introductory remarks, you think about the constellation of disease that we see. So someone comes in and they're obese and they have high blood pressure and their blood sugar is elevated. And I had one endocrinologist say to me, the best thing I could do for this guy is to take him for a walk, but I don't get paid to do that. And I think the point is, why not? Right. Maybe we should take some of the money we're spending and, of course, put it into prevention. And I think, you talk about all sorts of areas. And the problem with this wellness data right now is it all takes the view, we don't know how to prevent disease right now. But that's because we haven't tilted the playing field to encourage that. I guarantee you, if the incentives that we have for, if we're willing to pay hundreds of thousands of dollars, for example, for drugs that might improve life expectancy by 6 months, but we're not willing to spend anything on, say, meditation or whatever it is, and we haven't found a way to optimize it, then we can't say that the incentives are built in. We've tilted the playing field towards paying for treatment when you're sick rather than if you're well.
So whose job is it to change that? I mean, we got to get to that. I mean, whose job? Who should we be lobbying?
Donald Trump. No, I'm sorry. No, and that's a good question. So we talk about the employer. Who has the most vested interest in health? First of all, it's the individual more than anyone. Right. We talk about, and then we say about the employer. Well, the employer has an interest in health to the extent it improves productivity. But what employer is going to invest in preventing Alzheimer's? We're talking about people in their 80s that's well past their productive years, and I don't think we as Americans are ready to say that we shouldn't ensure quality of life. And then you think about health plans, and one of the, average tenure in some plans is 2.5 years, and so why would they ever invest? And if you look at Kaiser, for example, average tenure in a Kaiser plan is about 10 years. And interestingly, they do a lot more on the prevention side. They have the incentives. Now, you talked about the study of the bus driver versus the ticket taker. And if you go to the UK, they have a single payer system and they have incentives to keep people well throughout the life cycle. But again, they have problems investing. And actually, it's the social determinants that matter. So take the example of walking to work, okay, which is a very useful activity. And we all think, it would be very nice if everyone could live in Santa Monica like I do. And I think you're going to have a very nice building someday, perhaps, in Santa Monica. And, I'm looking forward to coming over and visiting you. But, our problem with diabetes in Los Angeles is in East LA. And the sidewalks are cracked, and you could make an argument it's not safe. And we make no social investment in these simple health improvements that might actually allow people to access that. So my concern with the digital revolution is we have a very bifurcated America. We have a set of people who, armed with technology, can really improve their health, much in the way we've seen that in diabetes, where people self-manage. On the other hand, we have a fraction of the population that is not able to access that, either because it's complicated or it's expensive or they don't have the infrastructure. And I worry about those people in that community.
Yeah, that's a good point. We've heard in all four of you talk about data as one of the key determinants in every aspect. You guys are making technology, you're encouraging research, you're analyzing it. Yet in none of these fields do we have data standards. Does that hold you back? I mean, are any of you limited by the fact that there aren't standard data elements, standard ways of collecting data, standard ways of describing the data?
Totally. I mean, one of the things we're trying to do right now is sponsor metrics that matter. To your initial point, which is, what is the universal metric for health? We just don't have one. And we talk about quality, and I don't think any of us would measure health by talking about quality, right? So we need to come collectively, I think, across the world to what those are. And many have tried, and I don't think anyone has quite succeeded yet. But I think when you ask who's responsible for that, no, if not us, who? That means all of us. It's what Kathy said from the very beginning, because we have to care. So aligning the incentives, I think, is sort of at the core of all of this. And you have to align the incentive to the individual, to the population, to the collective, overall. And that just hasn't happened yet anywhere in the world.
But it's tough because the time scale is so long. I mean, a behavior today, if you walk to work like James does, it may help him 30 years down the road. Right. How do you change a behavior today that's going to help decades from now?
No, and I think that is key. And that's, our problem is, the rapid technological innovation only comes from evaluation. And we have to get out of this mode that everything has to come from a clinical trial, because we're talking about wellness and prevention. And we need to know what the data tell us, and the ability to track individuals and understand their behavior is paramount if we're going to do that. And I think, to be honest, people are going to have to say, do we want to, as a society, make the deal that we're sacrificing some of our privacy in return for finding ways to improve our health? And that's a big question, but that's fundamental.
And do you think from the million-person study in March, on whatever, the million-person study, that you can actually develop an algorithm for what is health?
I think we're going to have a lot of data about what predicts future illness and disability. So we'll have a lot of data. The question is whether or not you can do something with that data. So being able to measure it, being able to predict, and then being able to preempt something from happening. And we really fall off in the last. So, there are some things we can do: diabetes, get exercise, lose some weight, but there's a million problems that people suffer from where we don't have effective interventions. And so we really need to continue to focus on the research. Sue responded to this question about data standards, and certainly we invest a lot in trying to develop some data standards. There's times when we're having too rigid a standard actually stands in the way of some progress. But one of the things I think that's really important when we talk about data as well is about data sharing. So we have...
You're pro-sharing.
I am pro-sharing, and I think that, but I work in an institution and in a community that really doesn't value data sharing. So data hoarding and the incentives around my data and my publications really is at odds with being able to collect, share, aggregate, analyze, and make real use of the data that we're investing in generating.
Yeah, no, I get that.
Yeah, I mean, the fact that there's startups that exist today solely to ask your hospital, your doctor, for paper records and CDs and then digitize
and then integrate them.
is ridiculous.
Yep, it's crazy.
And it's like having startups, I don't know if they still exist, that take your old slide collections and turn them into digital photos. It's pretty archaic, and it's great for those startups that there's a interesting enough business, but I think a sad statement on the state of the overall healthcare system. And the other thing too is HIPAA. I mean, I think a lot of good intent behind HIPAA, but what we find is that
HIPAA is the Health Insurers Portability Act for
And Accountability Act.
privacy.
Yep.
But it had one line in it about privacy, and you're probably going to talk about the privacy part of it, right?
I think there's too much ambiguity in it where we feel that sharing of data can result in better outcomes for patients and consumers, but it's very difficult to interpret how we should safeguard some of this data. And if you ask 10 different lawyers versed in HIPAA, you're not always guaranteed to get the same answer. So trying to navigate that system is pretty difficult for companies that face liability.
And I would also add to that, I think that's exactly right. When we were doing a study on patients with HIV, this was back in the 90s, around the time of the passage of HIPAA, and we wanted to find out who had died so we could see what is working. And we were told there's no way you can link to national death records because this is a very sensitive issue. Well, it turned out Equifax, one of the credit check companies, came to us and said, oh, we know who died. We'll give you that data. So, the irony is the research side, there are a bunch of people out here being very careful with data, and then your credit card company knows everything about you. So,
one of the hallmarks of a Fortune meeting is that obviously the audience many times, if not this time, is much more impressive than we are. So it's certainly you guys asking questions, and it's meant to be a discussion. So I know there are microphones circulating for questions in the room. So if you want to stand up. This is live streamed, so the microphone helps the people who are watching it around the country hear what you say. Hope it's right behind you.
Sure. What a great panel. Just a thought going back to the future. In 1948, the World Health Organization came out with a definition of health. Health is a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. And then the 3 Ps, and then I'll pass it on: personal health, public health, and population health. And we see very little integration in bringing the three different sectors together. So I think that's just the scene of what you're trying to do going forward. And then the last one would be about communications and the role of the digital communication process between the different generations, the different ethnicities. We really have to get the message more simple and elegant rather than more complex.
Can I make a plug?
So well said. Can I just comment on that? I think you're going to see that, in fact, the individual for precision health actually feeds the precision population health. And more the social determinants in health, which Dana was talking about, are being pulled into that. So there seems to be, from data, because it's becoming so digitized, an ability to start to move in that direction. And the other parts of it, I agree, are still missing, but you can feel that trend starting to happen overall. So the individual feeds the collective, and the collective feeds the individual.
Yeah, and in terms of pace of adoption, I mean, clearly we see the individual adopting these solutions much quicker. I mean, just at Fitbit, we've, throughout the history of the company, shipped over 40 million devices. That's a lot of people. The next phase that we see is definitely employers who could say are essentially in the business of population health, which is odd. That shouldn't be the function of a company, but they are. And what we see is actually a pretty virtuous circle where if we see devices deployed in an employer setting, actually what we see is that devices spread to their immediate family members as well. So there's a lot of positive impact from combining population health and the individual tightly together.
If I could add one thing to that, if you do these cross-national comparisons, the U.S., as many of you know, spends about 17 or 18% of GDP on medical care. If you look at the UK, they're spending about half that, maybe less. But it turns out if you add the social health and the social support that the government provides, that's also about 8% of GDP. And it turns out that, countries tend to spend around 20% of their GDP on wellness. It's just that in the United States, we've chosen to make that all personal health spending, whereas other countries are making different investments. And the question you're asking really is, what's the optimal mix for the United States?
Next question. 40 million devices. Whoa.
If you think about it, consumers have spent several $1 billion taking control of their own health, while the public health sphere and payers have kind of stood by watching all this time.
Interesting. Yeah. You want to?
I don't have a microphone, but I want to touch on the metrics that matter and how long do you think, with clinical trials and studying metrics that matter, it takes time, right? Because you want to collect data and then you want to see how it can be used for prevention, disease prevention. And then without genomics, how do you know someone has propensity to get a disease? So when it comes to metrics that matter, especially regarding physiological metrics off of wearable devices, how long do you think it will take? And will your million-person cohort or your cities actually deliver on that?
It's a great question.
So how long, just to make sure that I understand, how long will it take until we have a meaningful impact? So you mentioned genomics. I think it's, want to sort of riff on that for a second. I think some of us get almost giddy in thinking about what we can learn from genomes. And so if you have billions of base pairs on millions of people, that's pretty exciting. But I actually think that that data is puny in comparison to the real life, real time data that we will be able to collect. There was a paper, I think, a couple years ago from folks at MIT where they monitor people's movement and behavior in their own house by watching through wireless distortion, right? So I think we're going to be able to make correlations, important correlations between people's biology, behavior, social determinants. We'll be able to make those correlations pretty quickly and really ignite a lot of interesting subsequent research. One of the things I think will happen immediately in the very beginning is that we're going to develop a new and different relationship between researchers and research participants, where Together, we are figuring out what we want this to look like and what we want it to mean, which is really turning everything on its head. Usually, smart researchers sit in a place and come up with a great experiment, and then somewhere down the line, we engage the participants, not the subjects, but the participants, and ask them to sign a consent and give up themselves, right? We really want to have the participants with us at the beginning so that they have a motivation and incentive to stay engaged with us for the long haul.